the goal for taking care of children with cerebral palsy is really to help every single child grow up to live their very best life. And we need everything that we do, every intervention is a tool in a toolbox. And if you already don't know this as an orthotist, your tools are actually the most common tools used by these kids. So 95% of my patients wear an orthotic. I mean, it's actually the exception that you have patients that don't wear some type of orthotic. And if you talk about patients that wear an orthotic at some point during their life, it's probably closer to 99%. So what do you know about CP? Well, it's the most common physical disability of childhood. It's actually much more prevalent than people realize. In the United States, about 1 in every 300 school children has a diagnosis of cerebral palsy. It affects 17 million people worldwide. A third of these patients will not walk, and it exacts a huge financial and psychological toll on families over the course of their lifetime. What is cerebral palsy? Well, it's a group of permanent disorders, and the hallmark is a disorder of movement and posture. So if you don't have problems moving or maintaining an upright posture, you do not have cerebral palsy. So it's not just a developmental delay. It's not that just you're slow for walking. You actually move abnormally, and that you couldn't find a child at any developmental stage that would look like your child because your child's not moving normally. And not only do you have a disorder of movement, but it's enough of a problem that it actually causes a functional limitation. So occasionally we'll see patients that come in, and a smart neurologist or an astute neurologist or clinician can pick up the fact that they have a very subtle hemiparesis, which would be the most common scenario, where they're a little bit weaker on one side, or they have asymmetric reflexes, or they have spasticity on one side. But if they're walking and running and doing everything that every other kid is doing, and they don't need any assistance, you don't give them a diagnosis of CP. I mean, they may have an asymmetry, but you're the only one that would figure it out. And I actually had a patient when I was in St. Louis, a teenager that came to see me at the age of 14, who had gone to the orthopedic surgeon because he was having back pain. He had a slight leg length discrepancy, but he was a football player, and he was doing all this stuff. And the orthopedic surgeon looked at him and looked at everything, and he did have a rotational abnormality that you could pick up if you did an exam on a table, but not by looking at him. And he told the kid and his family that he had cerebral palsy, and the kid asked, "What's that?" And when he told him, the kid fainted right in front of him. So the family in a panic comes to see me. I'm having this kid hop up and down from here to that door, back and forth on either foot. I mean, I couldn't pick up a single thing until I got to like the reflexes and things like that. And I just told the parents, I said, yeah, he has a subtle difference between the two sides, and there is a neurological abnormality, but it's causing no problems, and you don't need to do anything about it. And I took away the diagnosis of CP. So it has to be a functional limitation. And cerebral palsy is caused by an injury to the developing brain, and it's not just one type of injury. Anything that attacks the developing brain or happens to the developing brain to cause a problem, whether it's viral or inflammation or trauma or asphyxia. And the reason I said asphyxia last is that only about 10% of cerebral palsy is actually due to birth asphyxia. Most cerebral palsy is not due to birth asphyxia, but anything that happens during development that it affects the brain can cause cerebral palsy. But it's not thought to be a progressive, it's not a progressive injury. It's a one-time hit or close to a one-time hit. There can be ongoing inflammation. But there's lots of patients that show up with a diagnosis of CP that actually can turn out to have something else, and it can be something slowly progressive. So for a long time they look static, but they do in fact have something progressive. And you might be, as the orthotist, the only one that actually picks up on it, that they're actually losing ground. And no, it's not because you put them in the wrong orthotic, or it's not because they weren't doing therapy. It's because they actually are slowly losing ground, and that's something that you need to alert people to. But the next big thing is cerebral palsy is a motor disorder. It's defined by the motor disorder, but it's really a syndrome, a group of syndromes. And the motor disorder is one piece. And in addition to that, most patients with cerebral palsy have one or more disturbances of something else, of vision, hearing, sensation, communication, epilepsy, cognitive impairment. musculoskeletal problems that happen because you move in a body that's not moving correctly. And so you really have to look at the entire syndrome in order to adequately treat these patients. How do we make the diagnosis? Well, the diagnosis of CP is actually made based on a good history and a physical examination, and typically either a history that accounts for other doctors' examinations over time, or you examine the patient over time to make sure that they have something that is, as best you can, that they have something that's static and not something that's progressive. And an MRI, which is a brain imaging, which I'm not going to bore you with and show you a bunch of MRIs, because there is no one type of MRI abnormality. MRI is helpful adjunct information, but you don't put up an imaging study and make a diagnosis of CP. And then sometimes we have to do other testing to make sure there's not other metabolic or genetic or degenerative problems. And interestingly, the most recent evidence and the most recent data from studies coming out show that up to 45% of patients with CP may actually have an underlying genetic problem, either causing or contributing to their cerebral palsy. And that's especially true for patients where they have really no risk factors for CP. They weren't born prematurely. There was no, they didn't have to go to the NICU or intensive care unit when they were born. There was nothing wrong. They go home from the hospital, everything's fine, and then all of a sudden they don't develop normally, and then they have spasticity, and they have what looks exactly like spastic diplegia or spastic quadriplegia with no obvious risk factors. A lot of those patients, maybe half of those patients, actually may have a genetic problem underpinning that. And now that we can do all this fancy genetic testing and whole exome sequencing, people are really starting to look at that. So how do we address these patients? I mean, Keith's already alluded to the fact that, I should say, by the way, Keith is very gracious. You know, he gives me all this credit, but you know, we basically went into the trenches together back in 1998, and as much as he thinks he didn't know anything about spasticity or dystonia, he's given me a lot of credit to think I knew anything about gait or walking or anything. I showed up in the CP Center with my own history of what I knew, and I knew that I wasn't going to give up on these kids, and I was going to figure out how to solve the problems, and I pull as many people in to help me as possible. But it was the physical therapist working with me day after day, and Keith, that taught me about gait and orthotics and bracing and walking and feet. And really, you guys probably already know this, but most doctors do not know gait at all. I mean, they neurologists will go look at somebody and say, oh, that's a typical spastic gait. One of the big things I tell the residents when I teach them is there is no such thing as a typical spastic gait. And you have to describe the gait. And you have to describe every little part of it and everything about the patient, or you're going to do the wrong thing. So you guys know more about feet and about walking and about things that have to happen than a lot of doctors, and so you really need to pick up the phone and don't be intimidated about talking to doctors, because, and if the doctor's like, you know, do it my way anyway, I mean, that's a big problem in this day, especially in this day and age where it's so hard to get funding for things, because you could actually be harming a patient if you're putting something on that kid's foot that you know isn't right, even if the doctor said to do it. You know, you can even, it's okay to say to a family, you might want to get an opinion from somebody else just to make sure, because you're bothered by this or this. If you stick to your guns and you've got a good reason, a reasonable doctor will listen to you, and that's how we make the best changes. I mean, I was really paranoid about leaving St. Louis because of all the people and the CP Center, my family. I left because I married a man who was from Texas, who I love very much, and I'm much happier because he's much happier, and I'm learning to be proud to be a Texan because he's here. But I was like, who am I going to work with? I'm going to Texas. I don't have Keith. Keith isn't going to come down. Well, I've met at least two orthotists that I can talk to, and one of them is sitting right here, Suzanne O'Connor, where I can actually pick up the phone and like the very first time and say, well, I'm worried about this or this. And she's like, well, yeah, I was too, but you know, she's one of the people that said I have to do what the doctor said. And I said, well, I'm the doctor. So let's figure out the best brace for this kid and write the right script, because in the end, it's the team working together, not like I'm right and I'm the boss and you have to do what I say. That's not the right approach. So we take a very complex approach and we try to break it down into all these different parts. But then the other big thing to remember is, as I said, is it's the motor disorder, but it's also all these other associated impairments. I don't think I have a pointer here anywhere, as far as I know. But sometimes, or a lot of times, these associated impairments are more detrimental to these patients than the motor disorder. And if they've got one or more of these things going on, and uncontrolled epilepsy, and they're not, especially if they're not sleeping at night, you're going to have to think long and hard before, am I really going to add one more thing to this family? Am I really going to give them a stretching splint that I know is going to sit in the closet? Even if you really think they need to use a stretching splint, the bottom line is, if they aren't sleeping at night and they aren't getting good nutrition and they have all these other issues, they've got a lot of other stuff that they have to tackle first. And the only thing you have a chance of getting on them is a daytime orthotic, because if they can wear it walking or doing something else. But you really have to look at the timing of what you're doing, and not just because of how old they are or their growth, but also what is going on in the rest of their life. So let's talk about the motor disorder. The motor disorders of CP are vast, and they go from the very mild to the very severe. But on top of all that, it's not just all spasticity, and there's all these different components that we look at to try to sort out what's going on. And so this is a twin. Her twin also has CP, but she's ambulatory. And Miranda has mixed spastic dystonic cerebral palsy. And she really gets stuck. She even thinks about talking. She gets all stuck and starts posturing and has a tonic neck. Her feet are strapped in, and her orthotics become very important, not only so she can stand in a stander, but so that she can keep her feet strapped in safely, and she can relax more in her legs so that her legs aren't sticking straight out of that wheelchair. But this is the description of her down in the lower corner. But we go through all these different things. What is the type of tone? Which limbs are involved? What is their motor function? What are the secondary deformities, their range of motion? And we put all these things together to try to come up with the best way to treat the motor disorder part of the cerebral palsy. So the CP is classified by several different methods added together now, but one of the oldest and most common way to classify patients is by their tone, which I'll get to in a minute, the type of tone they have, and the distribution of where the motor disorder is. And so one of the most common types of CP is diplegia, and diplegia means that your legs are predominantly involved and you have good functional use of your hands. There's actually triplegia, which is also pretty common, but there's no diagnostic code for that, not even in the new ICD-10. So we talk about diplegia. But diplegia does not mean you don't have a problem with your hands. It means that you have good functional use of your hands, or at least of one hand, and that your legs are predominantly affected. But if you have a neurologist examine a patient, they can find nothing wrong with their hands, no tendon, no reflex problems, no spasticity, nothing. You have to ask, and no fine motor problems, you have to ask, is it really a brain problem, or do they have a spinal cord injury? I mean, it becomes that simple. So your hands are involved in CP and diplegia. It's just that you have functional use of your hands. Hemiplegia, to be really purist about hemiplegia, it means that one side of the body is pretty normal functionally, and the other side is, there's an impaired side, like there is with adults with stroke, and the other side is pretty normal. Although there's lots of people, if you take 10 different doctors and show them a patient with hemiplegia, some of them are going to call that quadriplegia, some of them are going to call it hemiplegia, some of them are going to call it double hemiplegia and some mixture of something, because patients don't all fit into one category. And then quadriplegia for me is really somebody that has significant functional impairment of all four extremities. And then we also classify cerebral palsy based on the type of tone. And 75 to 80% of patients are classified as spastic, and that means that they have too much tone, they're hypertonic or stiff. But as you'll see in a minute, not everything that's stiff or hypertonic is spastic. And then the patients with spasticity are typically broken down into diplegia, hemiplegia, quadriplegia, but I just want to remind you that you can have somebody who's dyskinetic and diplegic, or dystonic and diplegic, or dystonic and hemiplegic. And the rarest type of CP are the kids that are truly hypotonic, which means, lots of kids with CP are hypotonic in their neck and trunk, but that's not what we're talking about. We're talking about just diffuse hypotonia where you're floppy all over. And if you have a kid that is floppy all over, you need to ask, even though you're the orthotist, you're not the doctor, and it shouldn't necessarily be your job. Again, you might be the last person in the chain and the only person that thought about it, but if they are truly floppy, then the question is, do they have a primary neuropathy or motor neuron disease, or do they have a myopathy, Duchenne's muscular dystrophy, congenital myopathy? Do they have something else besides CP? And they really need an evaluation. because that is much more rare. And then there's ones that people can't classify. So let's talk about spasticity for a second. What is spasticity? So when I ask residents this, or medical students, I get a variety of answers, and there's really only one correct answer, but the people say, oh, it's increased tone. I'm like, well, no, that's not correct. That would be hypertonia. Or it's increased resistance. It's increased resistance to passive movement. So increased resistance to passive movement gives you hypertonia. That means there's too much tone. Things can feel stiffer, but it's not spasticity unless there is a velocity-dependent component. And the reason I'm showing Morgan here on the water ski is to remind you of velocity and going fast. So by definition, spasticity means that when you move a joint through a range of motion, then as you move it faster, it gets harder to move. And most of the time, it gets hard enough to move that it stops, like the door that Keith was talking about that opens and gets stuck. It stops in the range of motion, and then it lets go. It's a sudden rise in muscular contracture that stops that range of motion, and then it often will let go, and that is the spastic catch. And that is the R1 that we're looking for all the time. And there's lots of different ways that people try to measure spasticity. And I'm part of several different working groups, and have been part of different working groups to try to come up with the best clinical measures for spasticity. I'll tell you, we still don't have a consensus because patients, for one thing, patients don't read the book. But there's a scale that I don't have up here because I don't like it, called the Ashworth, which while it measures stiffness or hypertonia, it doesn't really have a velocity-dependent component because you don't do things at different velocities. So really the only scale that measures, that's out there that measures velocity is the Tardieu scale. And there's the Tardieu scale score, and then there's the modified Tardieu score, which involves the R1 and R2. But it involves, there's a scale that it's very simple to do, where you just decide if they have a catch or not. And if they don't have a catch, do they at least have a change in resistance in response to increased speed? And then do they have clonus? Or does the clonus not fatigue, or is the joint immovable because it's so stiff? And that joint that's immovable, once the patient relaxes, you're able to move it. But you can see there's still a lot of wiggle room between those different categories. So the modified Tardieu actually measures that angle of the catch, of the spastic catch. And the way that it's done is you move the joint. So if I'm talking about spasticity in the elbow, and here we're talking about it at the knee, you move the joint through the full range of motion. That is your R2, and you have to move the joint slowly because some patients have so much spasticity that if you start to move it, it feels like it's just rigid right off the bat. And if it's truly spasticity, in most cases, you should be able to move that joint slowly enough, and sometimes it's like so painfully slow that you feel like you're not moving, that it will just evaporate. And I've done this with residents, and they can't believe it because they've gone in and they say, oh, they're rigid, and then I get the arm to go, they've got a contracture, and I get the arm to go all the way straight because you just have to move the joint slowly enough. The other thing to ask parents is what happens when they go to sleep? Is it easier to move them? Can you actually move that joint? But if you move the joint slowly enough, the spasticity should go away, and if there doesn't feel like there's any spasticity, if you move it fast enough and there's spasticity, you should feel that spasticity. And then so you always want to do the R2 first. The other mistake I see people making is they try to do the R1 first and then they push past it. And the problem with that is that, again, spasticity is always velocity dependent. So a lot of times when you move a joint slowly, there's also something called muscle stiffness that confounds this whole thing, where you can move a joint slowly and there's a point at which you get some resistance just from moving that joint slowly. And depending on if you're an orthopedic surgeon or a really strong physical therapist or somebody else, you're going to stop. I mean, a lot of orthopedic surgeons will stop at that resistance and call that their contracture because they know that kid is not going to push past that. And it's not spasticity, it's actual resistance. But, we get our therapists in there, we muscle to see, can we stretch it out any further than that? So the point of first resistance is not the same thing as R1, but both of those measurements are important. And this just shows you the gold standard for measuring spasticity. If we put an EMG, for example, on the quadriceps or on the hamstrings, and in this case, we're measuring both, the two EMG lines, and then you move and you put a rapid stretch on that muscle, you get a sudden burst, which is why the EMG spike goes up like a straight line and then comes down. That's spasticity. That is not normal. In a normal contraction, you get more of a bell-shaped curve where it builds up to a crescendo and then comes down. But in the spastic muscle, the velocity and contraction rises very quickly. This is looking at spasticity in the soleus, and when I move her ankle very slowly, you can see that she actually has good range of motion. You'll have to take my word for it that her midfoot is not breaking down, because this is the lateral part of her foot you're seeing. And then when you move her foot fast, not only do you get a catch, you actually have something called clonus, which is the most severe, really the most severe form of true spasticity. Once you get a rigid ankle, it's debatable whether you're talking about spasticity or dystonia, especially if that tension goes away when the patient relaxes. But so this is the spastic catch on the, let me show you one more time. And again, if it's not velocity dependent, you can't really call it an R1. You can call it the point of first resistance, which is still clinically important. So what's the difference between that and dystonia? Well, first of all, unless you have somebody videotaping you doing range of motion, to see something like this, you can't just look at somebody and say they have spasticity. If you see clonus, you know they have spasticity in their ankle. But you can't look at somebody and say, oh, that's why I get so upset about spastic gait. You can't look at somebody and say they have spasticity. You actually have to put your hands on them and move their joints through a range of motion. We have this whole detailed assessment, and we came up with a scale that we developed that we're working on getting validated while I was at WashU and Children's Hospital to differentiate between stiffness and spasticity and dystonia and range of motion and things like that. Whereas dystonia is something that you can almost always see. Although sometimes dystonia, if a patient cannot fully relax while they're awake, dystonia will masquerade as hypertonia because it causes a limb or an ankle, it's most often the ankle, sometimes the knee, that's difficult to move because that patient can't relax. But dystonia always goes completely away when you sleep, just like other movement disorders like tremor. True dystonia will go completely away while you sleep. And the other thing about dystonia is it causes postures that you just don't normally see. So then this is Michael, and he's much older than this now, and he actually has a genetic cause for his dystonia, but it took us a long time to diagnose it because the technology wasn't available. But you can see when when I put him on the table and I'm moving him, he's like a cooked spaghetti noodle. He's floppy. But as soon as you try to ask him to do anything, he gets all these postures, and they happen consistently every time. And some of these are really important postures. I mean, they're all important, but some of them are important for even kids with CP, with spastic CP. But you can see that you're getting all these things that you just don't see in the normal range of motion when you go and do range of motion. And so when I try to explain to people the difference between spasticity and dystonia functionally when it comes to moving a joint, if I just take my elbow again, just because I can't kick my leg and do all the fancy stuff Keith does, if you try to reach and you have spasticity, you will stop, and you might move slower because you're moving within your spastic range. If you have dystonia in your arm and you try to reach, you get this, and your arm pulls up like this, and you get all these funny postures, and you're not getting anywhere close to there. And dystonia is much more functionally limiting in most cases than spasticity. The kicker is, in cerebral palsy, you almost always have both. It's just a question of the teeter-totter. Which one is more prevalent, or are they both equally bad? So isolated spasticity is very rare. If you have a patient who's ambulatory and they only have spasticity and it's only in their lower extremities, send them to get a selective dorsal rhizotomy. There's nothing else that will touch that for a treatment for them. But it's very uncommon to have pure isolated spasticity. So then you have to talk about, okay, how much dystonia is there? In the same vein, if you have somebody that just has dystonia, like Michael, and it's only dystonia and you can't find any spasticity, you have to, it's a genetic disorder until proven otherwise. So in CP, and when you age with cerebral palsy, spasticity and dystonia both worsen with age, and the consequences of spasticity and dystonia, meaning contractures and bony deformities and things like that, worsen. And the other thing is, spasticity shows up early, but dystonia might not show up, and usually doesn't show up in a lot of patients until after the age of 2. And that's the age when, Dr. Park likes to do rhizotomies. And so it can get tricky because I get patients that come back, they had spasticity, they have diplegia, they get the rhizotomy, they come back and they say, oh, the rhizotomy didn't work. And I go examine them and I say, well, actually it did, they don't have any spasticity. What you're seeing is dystonia. And the rhizotomy doesn't take care of that part. But I still would have done the rhizotomy in a lot of these patients because it gets rid of the spastic component, and then you work on treating the dystonia. So it's really important that you understand, and also that you can educate your patients. And I just want to show you this video because if you remember Michael sticking his legs out, and this is a kid, she has spastic diplegia, but she also has dystonia. So scissoring of the legs, no matter what anybody tells you, true scissoring where you cross your ankles and cross your knees, that is dystonia. Limited range of motion at the adductors can be from spasticity, but true scissoring is dystonia. Sticking your legs out in extension like that, where you're trying to do, we do this little quick video on every patient where we do all these other tasks, especially while they're sitting and when we watch them walk, to bring out dystonia, and it's overflow dystonia. You have them doing something else with their hand, moving their hand, or talking. Talking is a very common way to bring out dystonia, especially if they get nervous and their legs shoot out. That is dystonia, and that dystonia will stop you in your tracks when you're trying to walk. And you can be having a great day in terms of your spasticity, because you can have stiffer days or not so stiff days. You can walk all around, you might move slower on a stiffer day, but then dystonia rears its ugly head in a split second, which is why I won't walk from here to that door in front of you, even with a cane, is because my dystonia kicks in and I'll be stuck to the floor or I'll fall over because everything goes completely rigid. It's why I have to have something to hang on to, because it's not that I don't have the strength in my legs, but the dystonia creeps in and you're just like this, like rigid, and you're going to go over. And it swings up and down. It has a mind of its own. And there's just another couple examples of a patient who's now long since graduated from high school. But you can see he's trying to do stuff and his legs start sticking out. So he's stiff to begin with. He has spasticity to begin with. And then he gets this dystonic posturing. And the problem is, you go and you stiffen from the dystonia, but you actually never fully relax in between like Michael did because you've got this spasticity underlying that. So it's very uncomfortable. And then this young lady, this on the young lady walking. She's actually one that came to me. I never met her before the rhizotomy, but she's like, oh, the parents are like, it didn't work. And the reason it didn't work is, it did work. Her spasticity's gone, but she's got dystonia. That's why she's up on her toes. That's why it seems like she doesn't have good range of motion, but once that dystonia gives way, she's got great range of motion. And then she stiffens up her legs and she can't walk. But the nice thing about a good orthotic is sometimes in milder patients, a good orthotic, because dystonia is very sensory responsive, a good orthotic with the right pressure points and holding the foot in a good position is enough to melt away enough of the dystonia that patients can go from not being able to take any steps independently to walking independently. And of course, it's never as complicated as spasticity and dystonia. It's always more than that. There's combinations, there's muscle stiffness. There's muscle stiffness partly because there's true mechanical changes that happen in patients with spasticity, where the actual physical properties of the muscle change over time, and it can happen very early. It may happen, it definitely happens by the age of 3 and may actually even happen before that. It does happen before that in patients with severe spasticity. And so then just treating the spasticity isn't going to do anything about the muscle stiffness component. And you get rigid hypertonia, you get mixed movement disorders. There's people that talk about hypertonic dystonia. And of course, you're still trying to get all the experts to agree on definitions of things. And then you have patients with just really severe mixed movement disorders where they have dystonia, they have a dystonic tremor on top of the dystonia, they have chorea with the quick movements in their hands. Lindsay's got her legs strapped in, otherwise her legs get really rigid and stiff. But this movement disorder is so disabling, and we are just not very good at treating it because I can throw every medicine that I have at her and every treatment that I have, and I can make her really loose and really weak so she can hardly move anything, so that she's more relaxed, but it's not going to make her functionally better. And this is where I really beg the scientific community, especially with these kids that are really trapped, this is why we need a cure for CP. To start by helping these patients right here, because there are no treatments that are effective enough for patients. But she does have orthotics. She has AFOs so that she can stand up, and she can stand up and take steps at a gait trainer, and she can stand up so that she doesn't break her bones. So we talked about the type of tone, we talked about the distribution, and so we've got diplegia, quadriplegia. So here we have 3 patients with spastic diplegia, but they don't look the same. So just saying that they have spastic diplegia and saying how much dystonia they have or whatever isn't enough, because it doesn't tell me that one patient's walking with a walker, one patient can run, and the other one is walking with canes.